Hi, this is Manos Brylakis, and this is video 19.2 for the Manual of Percutaneous Coronary Interventions. This video discusses how to do rotational atherectomy. Rotational atherectomy is one form of lesion preparation, and lesion preparation is the 9th of the 14 steps of percutaneous coronary intervention. There are multiple other different forms of lesion preparation. Most commonly, balloon angioplasty is used, but there is also orbital atherectomy, laser, thrombectomy, and intravascular lithotripsy. The basic premise of the mechanism of action of rotational atherectomy is ablation of tissue through a hard diamond-coated burr that spins at high rotation speed within the coronary artery. This is the currently available rotational atherectomy system, which is the Rotapro system from Boston Scientific. It consists of a console that displays the rotational speed as well as the time of rotation and allows adjustment of the speed. There is also an advancer that comes pre-connected with the burr. The advancer has an advancer knob that can be used to move the burr back and forth in the coronary artery. Activation happens by pressing the button at the top of the advancer knob. These are the various available burrs. They start from a size of 1.25 millimeters and go up to 2.25 millimeters. The most commonly used one is the 1.5 millimeters. The reason being that it is less flat compared to the 1.25 millimeter. The 1.25 millimeter is more like a bullet. Therefore, if it goes through the lesion, it may have a hard time coming back, since ablation for any Rotablator burr only happens in the distal part of the burr and not in the most proximal segment. Having rotational atherectomy requires use of an appropriate size guide catheter, which is 6 French for 125 to 175, 7 French for 2.0 millimeter burr, and 8 French for 2.15 and 2.25 millimeter burrs. Rotational atherectomy requires use of dedicated guide wires, which is the Rotawire. It comes in two types, the Rotawire floppy and the Rotawire extra support. Both guide wires are thin, they're 0.009 inch, but their tip is 0.014 inch. And this is critical to know because that means that the burr should never come in contact with the distal part of the wire because it may lead to fracture and loss of the guide wire tip. The Rotawire floppy is the one used in the vast majority of cases, with the Rotawire extra support being reserved mainly for ostial lesions. There is also a wire clip torquer that can be placed off the guide wire to prevent inadvertent rotation of the guide wire inside the coronary artery if the brake mechanism of the Rotablator device is defeated. Video 19.1 discusses when coronary atherectomy should be performed. But in brief, coronary atherectomy can be performed either in a primary fashion or in a secondary fashion after failure of balloon angioplasty to modify the lesion. Primary rotational atherectomy can be performed in heavily calcified lesions that do not have significant tortuosity, thrombus, dissection, and are not a bypass graft. Secondary atherectomy is done if the balloon cannot cross or if the lesion cannot be dilated despite balloon inflations. How to choose between orbital and rotational atherectomy? For most cases, either form of atherectomy can work. However, for balloon uncrossable lesions, the forward cutting mechanism of rotational atherectomy may make it advantageous in the setting, whereas for large vessels, orbital atherectomy is preferred, as with the same burr, one can modify larger vessels. These are the steps of rotational atherectomy, starting with preparatory steps and then 11 steps for actually performing the procedure. The first questions to address before proceeding with rotational atherectomy is number 1, whether a pacemaker is needed, and number 2, whether hemodynamic support is needed. Pacemaker is not needed in most cases, But in patients in whom atherectomy is done in the right coronary artery, it may be needed. An alternative approach is to use aminophylline that prevents the bradycardia by antagonizing adenosine that is released from the red blood cells broken down during atherectomy. The question of hemodynamic support can be challenging to address, and that will be discussed in a separate video, but performing atherectomy does carry a risk of distal embolization and potentially acute vessel closure that could be detrimental, especially in patients who have poor baseline hemodynamics. Therefore, in patients in whom there are poor hemodynamics or they have low ejection fraction, large area of myocardium at risk, severe valve disease or severe pulmonary hypertension, prophylactic use of hemodynamic support can be considered. As discussed, temporary pacemaker is not needed when performing rotational atherectomy in a LAD or a non-dominant circumflex. It may be needed in the right coronary artery, but alternative options is to either use aminophylline prophylactically, 250 milligrams IV over 10 minutes, or to perform a test run of rotational atherectomy to see if bradycardia is being induced and whether a pacemaker is actually needed. An alternative way for performing pacing is through the coronary guidewire. This is performed by placing the alligator clips on one of them on the coronary guidewire and the other one on a needle that is inserted through the patient's skin. Once the question of the pacemaker and hemodynamic support has been addressed, the next step is to select the size of the burr. In general, the burr should be half or less the diameter of the target vessel. For example, for a 2.5 millimeter vessel, a 1.25 millimeter burr should be used. For most larger arteries, a 1.5 millimeter burr is being used. One does not necessarily need to go big on the burr. A smaller burr, such as the 1.5, can provide enough modification to allow equipment delivery and lesion expansion. Also, the burr selected should be able to fit within the existing guide catheter, and this is important for planning. If the operator is planning to use a larger burr, then a larger French guide catheter should be selected. The second step is to engage the target vessel. That should be done with guide catheters that provide support. It should be done in a coaxial manner, and pressure dampening should be avoided because pressure dampening can potentiate the adverse impact of the distal embolization happening during ablation of the lesion. One wants to have good antegrade flow that can essentially clear away any debris that is liberated during rotational atherectomy. The third part is to insert the Rotawire over which rotablation is going to be performed. Those wires are not very easy to handle, and that is why many operators, including myself, prefer to use a workhorse guide wire and a microcatheter to wire the lesion, and then remove the workhorse wire and use the microcatheter to exchange for the Rotawire. If a manipulation of the Rotawire is needed, it is best to be done using the wire clip torquer, and if the guide wire becomes kinked, it should be replaced, otherwise it can fracture during rotational atherectomy. The fourth step is to administer a vasodilator unless the patient is hypotensive. Several, such as nicardipine, nipride, verapamil, or adenosine can be used, with nicardipine being preferred in our lab due to its prolonged duration of action and less hypotensive effect. Step number 5 is to prepare the Rotablator, and this is done using the acronym DRAW, which stands for DRIP, for D, R for RPM, which means we want to ensure that the burr is spinning at the desired speed, usually between 140 and 160,000. A stands for advance, the advancer knob to make sure that the burr is moving without any difficulty. And fourth is the wire. Ensure that the brake is working by trying to pull the wire back. Also, always want to have the wire clip torquer attached to the back end of the wire in case the brake becomes defeated during the procedure. Also, the advancer knob should be locked about 2 to 3 centimeters from the distal end. This is an example of how the preparation is done. This is the Rotablator burr that is inserted over the Rotawire that has been inserted into the body. The burr is advanced until the wire exits from the back end of the Rotablator device. Once this is done, then the wire clip torquer is placed over the back end of the wire. So now we have the wire clip torquer being placed, and then everything is kept in place in order to perform the plateau and make sure that the Rotablator is spinning. So by pressing the button, the Rotablator is activated, and then it can be checked on the screen to ensure that the desired speed is selected, which is 150,000 RPMs in this particular case. Step number 6 is to deliver the burr proximal to the lesion. This can be done either using trapping, if the guide catheter is large, or by fixing the guide wire and advancing the burr under fluoroscopy. Once the Rotablator burr reaches 1 to 2 centimeters proximal to the target lesion, then the advancer knob is moved all the way back to release any tension that has accumulated on the burr. And this is how this is performed. The Rotablator has been prepared. This is the two-operator technique. The operator on the back is fixing the Rotawire, while the operator in the front is slowly advancing the Rotablator burr through the TUI and then through the guide catheter until it reaches 1 to 2 centimeters proximal to the lesion. It is very important to coordinate the advancement between the operator on the front and the operator on the back. If one moves faster or slower than the other, then the wire can either come back or go forward. So this advancement is done while continually looking at the monitor and ensuring that the guide wire remains in place. If the operator on the back reaches the limit of movement, then he gives a signal to the operator in front, then there is movement of the hands, the wire is fixed again, and then the Rotablator burr is slowly advanced until the burr reaches 1 to 2 centimeters proximal to the lesion. If there is any difficulty, then operators should stop and determine what the reason for the problem is. And then once the burr is in the desired location, then a few towels are placed under the burr to facilitate performance of rotational atherectomy. It can be sometimes difficult to deliver the burr because of tortuosity in the coronary vessel, poor support, poor non-coaxial engagement. And the way to prevent this is to use smaller burrs or first do balloon angioplasty of the vessel and ensure good engagement of the guide. If there is difficulty, one can gently pull back the Rotawire or use the Dynaglide mode in which the burr is spinning at slower speed than the ablation speed. Use guide extensions or initially rotablate the proximal segment to the target lesion. Step number 7 is to actually perform the atherectomy. And there are several tips for doing this in the best and safest way. First of all, one has to ensure that the drip is on and that the wire clip torquer is on the back end of the wire. It is important to do atherectomy in a pecking motion without leaning on the lesion and staying away from the tip of the wire because, as we discussed, this is thicker, 0.014 versus 0.009, and therefore, if one goes close, there is a risk of fracturing the tip of the wire. Also, there should be no deceleration that is pronounced, ideally less than 5,000 RPMs. Keep it short, wait for several seconds between the runs, monitor the EKG and the pressure, and perform angiography if needed. This is how rotational atherectomy should be done. Again, this is a back and forth movement. It's completely different. It's actually exactly the opposite than doing orbital atherectomy, in which there is slow forward motion. Here, there is pecking motion, back and forth. The goal is to touch the lesion and come back. This minimizes the risk of burr entrapment and also optimizes the perfusion of the vessel, so the risk of no reflow is reduced. This is an example of movements back and forth and back and forth. Now eventually it moves forward. Now that was a moment of danger because the burr went very close to the distal tip of the guide wire, and this is something that should be avoided. Decelerations should be avoided. The RotaPro console provides some visual indication of decelerations. There is a yellow triangle for decelerations of 5,000 RPM or more, and if they are more than 10,000 RPM, then actually becomes a solid yellow triangle, giving a warning to the operator. There's also often an auditory change on the pitch of rotational atherectomy. It is important to keep the runs short. Long runs liberate more debris and give less time to the coronary circulation to clear this debris. So ideally, you want to have short rotablation runs, if possible less than 15 seconds, and give a lot of time between sequential runs for this debris to clear. The example, the analogy, is with dropping flour in a sink while water is running. If a lot of flour is dumped at once, then the sink can actually plug up. But if the flour is dropped slowly, then there is enough time for the water to take the flour with it and prevent plugging up of the sink. This is an example of a patient with a heavily calcified diagonal lesion that has tortuosity as well. In that patient, balloon angioplasty was tried, but nothing could be delivered through the lesion. And in cases like this, where the lesion is balloon uncrossable and undilatable, that's where rotational atherectomy can be very useful. The patient came back, then a microcatheter was used for delivering the Rotafloppy wire. And after doing that, then there were runs with rotational atherectomy. Once again, one does not want to lean for too long on the lesion. It has to be more of a pecking motion. And sometimes it may take several runs for the burr to go through the lesion, especially for heavily stenosed lesions, tightly stenosed lesions like this one. In this particular case, it took 10 runs until finally the Rotablator burr, and this was the 1.25 millimeter burr, went through the lesion. But this provided a nice result with resolution of the patient's symptoms. This is an example of not to do. You do not want to be leaning on the burr, pushing for a prolonged period of time on the burr. You want to actually go back and forth in a pecking motion and not lean on the lesion for too long, both for lesions of distal embolization, but also for potentially breaking the guide wire and causing distal fracture and perforation. There is a separate video, 19.4, that discusses potential complications of rotational atherectomy that include no reflow, decreased undergrade flow, perforation, entrapment of the burr, arrhythmias, and rotawire fracture. After rotational atherectomy is completed, the next step is to remove the burr. This can be done similarly to insertion using the trapping technique if a large guide catheter is being used, or by using the Dynaglide mode, in which the wire clip torquer is placed in the back of the wire, and then the Rotablator burr is removed while monitoring the wire position under fluoroscopy. So to activate the Dynaglide mode, then there is pressing the button, Dynaglide button on the back of the device, and then pressing the brake defeat button, making sure once again that the wire clip torquer is attached to the wire. This can also be done by a single operator. This is an example from Dr. Dwayne Pinto showing how to defeat the brake and then monitor with fluoroscopy the position of the wire, but just remove the burr as a single operator while having to do this as a two operator. The next step, step number 9, is to check the result. Ensure that there is good undergrade flow without no reflow, dissection, embolization, occlusion of side branches, or perforation. Then, to proceed with PCI, It is best to replace the Rotawire with a standard workhorse guidewire. As the Rotawire is thinner, it's less supportive and more likely to be kinked. This is typically done using the trapping technique and a microcatheter, similar to the original insertion of the Rotawire. The final step, number 11, is to perform balloon angioplasty. This is particularly important because sometimes modification of the lesion with rotational atherectomy is not enough and additional treatment is needed. This should be done with a non-compliant balloon that is sized 1:1 with the target vessel. Also, intravascular imaging is often useful to determine that there has been enough modification of the lesion. If there is insufficient expansion of the balloon, then repeat atherectomy may be needed to better prepare the lesion and facilitate equipment delivery and expansion. So in summary, rotational atherectomy involves 11 steps. Before starting the steps, one is to consider whether a temporary pacemaker is needed and whether a hemodynamic support prophylactically is needed as well. Then one proceeds systematically through steps 1 through 11 of rotational atherectomy, ensuring that those are done in a sequential way, very carefully and thoughtfully. There is no need to rush a step. One is to take the time and do them as careful and methodical as possible to achieve the best possible result. Thank you very much.